Welcome to the NeoFOCUS-UK Education Group webinar series.
Today. So it gives me great pleasure to introduce Dr. Neil Patel, who's going to be talking to us about the hemodynamic precision to guide the timing of CDH repair. Neil is a neonatologist at the Royal Hospital for Children in Glasgow, Scotland. He's got a clinical and research interest in neonatal hemodynamics assessment and management, including in the case of congenital diaphragmatic hernia. And Neil's other interests are clinical innovation and family integrated neonatal care as well. He's the Clinical Innovation Director for the Royal Hospital for Children in Glasgow and the Clinical Lead in the West of Scotland Innovation Hub. He's also our Vice Chair of NeoFOCUS UK and Visiting Professor at the University of Strathclyde and Associate Professor at the University of Glasgow and NHS Research Scotland Senior Fellow. So it gives me great pleasure to hand over to Neil for what's going to be a fantastic talk. Thanks very much, Neil.
Thanks so much, Liam, and really grateful to everyone for the opportunity to speak with you today on this topic, and looking forward very much to the discussion afterwards, especially with the terrific friends and experts on the panel here. So I'm just going to share my screen and hopefully you'll see my presentation okay. Great. Let me know if you can't see that, but otherwise I'll assume that you can. So today we're going to be talking about hemodynamics precision to guide the timing of congenital diaphragmatic hernia repair. And what I hoped to cover in the talk was, first of all, thinking about what are the factors that have been incorporated to think about the right time to repair CDH. And we'll take a bit of a historical perspective and think about the different kind of paradigms that have been applied, early versus late, the need for physiological stability, and that will bring us up hopefully to our current approach, which I would suggest to you is what we might call a precision medicine approach, incorporating hemodynamic characteristics. I'll also briefly touch on ECMO and timing of repair. So I think that's a different consideration, and we'll discuss why. And then briefly at the end, just think about other exceptional situations that might need a little bit of special thinking. So you're all familiar with CDH as a condition, I imagine. As you know, it's a relatively common rare condition where there is a developmental abnormality in the diaphragm, typically rather on the left-hand side, but in around 15% of cases on the right-hand side, and in less than 1% of cases bilateral. And in terms of all of the conditions that we treat in the neonatal period, particularly congenital anomalies, I would argue that CDH is one of the most severe. We know that in the current era, mortality, even in the best centres, remains somewhere between around 20 to 30%. So 1 in 4, 1 in 5 babies affected sadly will not survive. And a lot of that mortality is early neonatal mortality in the first days or week or so of life. So there's work for us to do to improve our management strategies to hopefully address what might be reversible mortality. But even for those patients who survive, we know that CDH is a condition that carries very significant morbidity, both in the early neonatal period, but actually beyond that into infancy, childhood, and potentially into adult life. So again, important opportunity for us to address and improve on that. And the timing of repair in this condition may be an important factor in that. Just thinking about repair itself, surgical repair of the diaphragm is a core component of CDH management. Certainly in terms of neonatal CDH, there are no patients who progress either with survival or with ongoing aspects of development without having their diaphragm repaired. So it's an essential component of the care we provide. And yet, as we'll see, there's relatively little evidence to guide us on when is the right time to do that. So I'm going to start by thinking about the timing of repair, and this is in non-ECMO patients. And the first construct around this was the concept of early versus late repair. And if we go all the way back to the mid-20th century, when the first reports of neonatal repair of the diaphragm really came through, we can see that what was advocated there was an immediate repair. So this is a report by Edward Donovan, who reported repair in neonates from his own experience, but also summarized in this table the other previously published reports, including just before this one, the very well-known report by Gross and Ladd. And all of these authors were managing these patients in a time when neonatal intensive care really didn't exist. And so from their perspective, the only option to potentially get a good outcome was to immediately repair the hernia. And you can see that was the recommendation here at the bottom. Surgical repair should be advised immediately for all cases, whether either small or large intestine is in the chest, because of the, and it was interesting that they said that because of the danger of intestinal obstruction, but as much as that risk, there was the risk that these patients just weren't going to survive without something that would support an improvement in their cardiorespiratory function during the neonatal transition. So this really led in those early years to the concept of early repair in CDH. But as the decades evolved up following that, and neonatal care and neonatal intensive care started to emerge as an area of clinical specialty, the concept moved on from a simple early versus late to a concept of physiological stability. And this is a report by Bowles and colleagues in Ohio, where they reported for the first time, I suppose, the early origins of intensive care stabilization in these patients. In fact, components that we would recognize as being key to our management of CDH in the modern era. So if you look at table 1 on the top left here, they inserted a nasogastric tube, they intubated and ventilated these patients, they put in a central line, they monitored things like blood gases, and they thought about correcting acidosis and, very importantly, keeping these babies warm. And they also had a strategy around the operation itself. So they performed that after resuscitation, so a delayed approach. And they incorporated insertion of a chest tube, and in this case, of gastrostomy as well. And in the table on the right-hand side, table 3, you can see that they compared the outcomes during the period in the early 60s where they didn't perform this planned preoperative management or resuscitation, and then in the late 60s and up to 1970 when they did. And they saw an improvement in survival with mortality falling from 76 to 28%. So this is starting to report the idea of physiological stabilization before repair. And that was explored more into the 1980s. And this is a report from a group in Toronto at that time who included Des Bone, who really led a lot of the thinking about physiological stabilization of these babies during that era. And here they compared what they called group 1 in the early 80s and group 2 in the mid 80s, where they moved from very early surgery before 8 hours of life to later surgery after 8 hours of life. And the first thing you notice between those two groups is that actually in the second group, a lot more patients actually died before surgical repair. So that was one of the consequences of delaying repair, that some babies just couldn't be stabilized and didn't get to the point of repair. But in the group who were repaired, they saw improved survival. And when you look at the table on the right-hand side, you can see if you compare mortality, it was slightly higher, 58% in group 1 compared to group 2. But the conclusions of this group were that early repair in the face of labile respiratory and hemodynamic function may be harmful. They suggested that emergency surgery was not necessary, and therefore repair should be deferred only should be referred until the patient had been satisfactorily stabilized. So this was just reinforcing this movement into an era where it was delayed repair based on physiological stabilization of the patient, and specifically respiratory and hemodynamic stabilization. This is one of the few RCTs that have looked at timing of repair in CDH. And it's actually the only one that looked at it in non-ECMO patients, and it's from 1996 from a group in Leeds. And they compared early repair, which in this case was patients who received repair at a mean of 6 hours of age, but interestingly up to 264. I'm not quite sure how they fell into the early surgery group, but as you see, overall in this group, mean surgery within the first 12 hours of life. compared to delayed surgery group who had median age of repair, of 48 hours of age. And what they observed was a trend towards improved survival in the delayed surgery group, although it wasn't statistically significant. And again, the feeling was based on this evidence that actually delaying repair, waiting for physiological stabilization may be the better approach. And that is the approach that has persisted for a number of decades since and has been written into guidelines, including the Euro Consortium guideline, the latest version of which is now nearly 10 years old, from 2016. And this is a recommendation regarding timing of surgery from that guideline. It says surgical repair should be performed when after clinical stabilization, so this idea of physiological stability, defined as a mean arterial blood pressure normal for gestation, preductal saturations 85 to 90%, and an FiO2 of less than 50%, a lactate below 3, and a urine output less than 1. But the grade of recommendation is a D, which corresponds to non-analytic studies, case reports, case series, and expert opinions. The actual evidence for this is actually pretty low. But again, it highlights that even in this modern era, much of the guidance for timing of surgery is based on physiological parameters, and really the secondary demonstrating characteristics of cardiorespiratory stability. And just to highlight the current approach to timing of surgery and what that practically means in terms of how old babies are when they're being repaired. If we look at this nice data from the CDH registry, which includes, well, the registry itself, as the title says, includes over 5,000 patients. But in this particular analysis, there are many hundreds of patients in different eras from the mid-90s to the late 20-teens. And just comparing those era 1 and era 5, you see the trend that has gone from early surgery in the mid-90s, with around 23% of babies being repaired on day 1, towards that trend of later repair, which in practical terms means repair somewhere between day 2 and day 7 in general. A significant proportion, 28% in era 5, being repaired at day 8 plus, but the majority somewhere between day 2 and day 7. So we've talked about that historical perspective of initially early versus late, and then the concept of physiological stability. Can we think about more precise ways of defining physiological stability? That's certainly something that in the past decade or so has been considered, and specifically thinking about how we incorporate pulmonary artery pressure in our understanding of when might be the right time to operate and to identify the optimum physiological point for repair. We're all aware that pulmonary hypertension, especially early postnatal pulmonary hypertension, is a key component of CDH pathophysiology, but that it's variable. Some patients may have mild, some patients have a moderate, and some patients may have severe pulmonary hypertension based traditionally on echocardiographic assessment. And this is a nice reflection of that from this paper by Judith Lyons and colleagues from the group of Florian Kipfmuller in Bonn at that time. And what they described in the figures here, in figures B, C, and D, are the levels of pulmonary hypertension in mild, moderate, and severe patients, characterized by their early pulmonary hypertension, but then following their levels of pulmonary hypertension over the first 48 hours of life. And perhaps not surprisingly, what you see is that in the mild group in the top right, the majority of patients have mild pulmonary hypertension, a small number have moderate, and by and large, pulmonary hypertension remains stable within the first 48 hours. In the moderate group in the bottom left in panel C, a greater proportion start off with moderate pulmonary hypertension in yellow, but over the first 48 hours, that tends to improve, and a greater proportion have mild pulmonary hypertension. And then finally, in the severe group in panel D in the bottom right, the majority have severe pulmonary hypertension. That's why they're classified into that group at the beginning. But over time, the pulmonary hypertension improves in the first 48 hours. And you can see that by 48 hours of life, the majority of patients have moderate or mild pulmonary hypertension. So this data reinforces for us perhaps that waiting for pulmonary hypertension to improve and having some objective way of assessing it will help us to identify when might be a point of physiological stability, certainly in terms of pulmonary artery pressure, and therefore help us to guide timing of surgery. And that's an approach that's been applied by a number of investigators. This is a group from Japan who reported 4 cases of CDH where they used the pattern of ductal shunting to identify the time for operation. So if you look at each of the 4 cases is represented by a horizontal bar on the right-hand side. The diagonal lines represent right to left shunting in the duct. Vertical lines represent bidirectional flow, and white space or absence of lines represents a left to right shunt. And their criteria for repair was the appearance of a left to right shunt. And you can see within these 4 patients the variability in that. Perhaps not surprising based on the data I showed you in the last slide, where we know that CDH is a spectrum of disease. And as in case 1 or 2, some patients will either have early evidence of left to right shunting or indeed predominantly left to right shunting throughout, in which case in this series they tended to be repaired earlier. Compared to other patients, for example, patient 3, who started off with right to left shunting in the duct that persisted throughout most of the first 48 hours of life, then became bidirectional and didn't actually reach a left to right shunt until the second half of day 2. And that's when they were able to identify the time for operation at that point. And then the 4th patient, as you see, again, had predominantly bidirectional flow until just after around 36 hours of life, and again went on to have an operation at day 2. Interesting that in this cohort, overall, the repair was quite early, and we'll come back to that later. Another group from Japan who also reported using assessment of pulmonary artery pressure to guide timing of surgery in 2 different eras. So in this case, again, they used the direction of ductal shunt, as you see on the left-hand side of the image here. And what they did is they traced the velocity time integer of the left to right component above the line. So that's shunting going from the aorta to the pulmonary artery, and also traced the VTI of the right to left component. And they calculated this LR ratio, which really expresses the percentage of total flow in the PDA, both the left to right and right to left components, and expresses the left to right component as a percentage of that. And they introduced this new protocol where they said we would operate when that ratio was less than 50%. So that kind of implies that that you're getting more left to right flow, and therefore that arguably the pulmonary artery pressure is starting to become below systemic pressure. And in the table on the right-hand side, you see the results of comparing an ERA that they called the control group, where they didn't use this criteria, and then the protocol group where they did use it. Now, you have to take into account, if you actually look at the LR ratio on the first 3 days of life in the 2 groups, that actually both were pretty similar. They both started with an LR ratio roughly around 50, slightly below 50 in the control group. But then in subsequent days, the ratio seemed to switch and was predominantly left to right from that point onwards. So perhaps we're not actually comparing 2 different groups of patients. We're and actually, although this new criterion was used, it may not have distinguished the actual differences between the 2 groups. Nevertheless, having applied this criteria in group 2, they saw a reduction in the ventilation time, duration of ventilation, and the duration of ventilation after surgery. So potentially some early data with a signal supporting an objective assessment of pulmonary artery pressure to help guide timing of surgery. This is a more recent study in Journal of Pediatrics by the group in Denver who took a similar approach. They compared 2 eras, and in the second era, they applied an objective criteria for timing of repair, which was a pulmonary artery pressure less than 80% of systemic blood pressure. And their means of assessing pulmonary artery pressure is listed in table 1 on the left-hand side, and they used 3 different approaches to use that. The first was looking at flow across the PDA, so a little bit like the Japanese group, but in this situation, they actually used a Bernoulli equation. So the velocity of the flow, both in the left to right direction and right to left direction, to assess systolic blood pressure. They also used systolic blood pressure, right ventricular systolic pressure estimated using TR velocity jet, again using the Bernoulli equation you see there. And then if the patient had a VSD, they also used the velocity of flow in the VSD, both left to right and right to left components. So that was the measures that they used to try and determine pulmonary artery pressure. And when we compare the outcomes within the 2 groups, group 1 before they implemented that criteria for repair and group 2 afterwards, what you see is there a comparable group of patients. Interestingly, this second group had a higher rate of primary repair, so maybe that suggests they were slightly milder cases, but similar rates of ECMO and other measures of severity. But what's not in that table, but I've picked out of the paper, is also the 30-day survival. It was 80%, so already a pretty impressive survival rate in the group before they started to implement that criteria. And after implementation in group 2, survival was 94%. Again, was that criteria alone sufficient to bring about a difference in survival? Difficult, as in many retrospective studies in CDH, to highlight one thing, but perhaps it points more to a more hemodynamic focused approach to selecting time of repair and the potential benefits of that. And if we look at one of the more recent guidelines for CDH management from the Canadian Congenital Diaphragmatic Hernia Collaborative, which was published last year, you can see that their criteria for surgical repair kind of incorporate those existing recommendations around physiological stability, but also incorporate something about estimating pulmonary artery pressure. So their criteria are, in a general sense, physiological stability, with specific criteria of based on urine output, FiO2 less than 0.5, pre-ductal saturations in that range 85 to 95%, a normal mean arterial pressure for gestational age, so similar to the European guideline before this one, lactate less than 3, and they added in estimated pulmonary artery pressures less than systemic. Again, these are consensus recommendations based on relatively slim actual evidence to support them, but that's often the way with CDH. So we've talked about the historic early versus late approach, the approach of broadly defining physiological stability, of then introducing some assessment of pulmonary artery pressure, particularly using ductal shunting direction to guide timing of surgery. I'd like to bring us up to, I suppose, our current thinking, which is incorporating an assessment of cardiac function as well, both in the right and the left ventricles. And to do that, I'd like to just talk a little bit about cardiac dysfunction in the early neonatal period in CDH. And apologies if you've heard me talk about some of this before in different times, but I just wanted to reiterate this because I think it is kind of fundamental to then how we use this information to potentially guide timing of surgery. So as we've seen from the work that I showed you of Judith Lyons and colleagues, pulmonary hypertension in the early postnatal period is a pathognomonic finding in CDH. And traditionally, we think that one important mechanism of that pulmonary hypertension is abnormalities in the pulmonary arterioles, specifically fixed increases in resistance due to thickening of the muscular and adventitial layer, giving rise to reduced vessel caliber and increased pre-capillary resistance in the pulmonary circulation. And we think that there's also a dynamic element to that increased PVR, which prevents the normal vasodilatation and drop in pulmonary vascular resistance at birth, and therefore gives rise to this persistent pulmonary arterial hypertension that, as I say, you saw that lovely demonstration of in that series, in that slide that I showed you. And the downstream effects of that elevated pulmonary artery pressure are, of course, to promote right to left shunting across the atria and across the duct that will lead to systemic hypoxia. But it also increases afterload in the right ventricle, which fairly quickly will lead to the changes that you see in the apical four-chamber view here of a dilated, hypertrophic, tachycardic right ventricle, which we know will have particularly diastolic dysfunction. And that dysfunction, the right ventricle, will give rise to reduced ventricular outputs and uncoupling from the pulmonary circulation, reduced pulmonary blood flow, and ultimately reduced reduced gas exchange as a result, and potentially a contributing factor at high CO2 in these patients. As you also see in that image, right ventricular dysfunction associated with septal displacement and secondary dysfunction in the left ventricle, and it's an important mechanism of secondary left ventricular dysfunction. But we also know that primary left ventricular dysfunction is possible in CDH, and you see that in the echo loop on the left-hand side here. This is a baby in the first few hours of life in CDH, and that left ventricle, even subjectively, has severe dysfunction. There's really no change in the morphology of that ventricle during systole and diastole. And this is a consistent finding now that we've seen repeatedly, both in series from our own center and from many other centers. We know that early left ventricular dysfunction may occur in anywhere between 40 to 60% of CDH cases, more so in more severe cases, but it can occur in milder cases. And as this kind of schematic diagram aims to illustrate, this left ventricular dysfunction is an important mechanism potentially of post-capillary increase in pulmonary venous pressure. So a post-capillary mechanism of pulmonary hypertension. That pulmonary venous hypertension will also contribute potentially to pulmonary edema and impair gas exchange. But it will also have those downstream effects that we talked about of pulmonary hypertension, promoting right to left shunting, right ventricular dysfunction, reduced pulmonary blood flow, combined with reduced systemic blood flow due to low LV output. And you can see that clinical phenotype, or the physiological instability that we see in these patients, that historically had been used to influence timing of surgery, could all potentially be influenced by left ventricular dysfunction when it's present, driving hypoxia, hypercarbia, hypotension, and metabolic acidosis in these patients. So with that knowledge and understanding that has kind of accrued over the past 5 to 10 years of these different cardiovascular phenotypes in early CDH, we can potentially incorporate that into our thinking about how we might time surgery. And just to reiterate what those phenotypes are, we may see some patients who have good cardiac function, as represented on the left-hand side of the screen. The ventricles are coupled to their respective circulations. We may see patients with more of a right ventricular dysfunction phenotype, with predominantly precapillary pulmonary hypertension and right ventricular dysfunction dilatation, but relatively preserved LV function. Or we may see patients with more of a left ventricular dysfunction dominant phenotype, as represented in the third image here, with a pulmonary venous hypertension phenotype. And these are the ones that might be more likely to have a left to right shunt to atrial level. And then on the far right-hand side, those patients who have a biventricular or mixed phenotype, often the most severe patients. And this is recent work from the CDH registry led by Carolyn No that just illustrates the frequency of right and left ventricular dysfunction in CDH in the different patients with different severity based on the size of their defect. So A's and B's are small defects, C's and D's are bigger defects. And what you see is, not surprisingly, that with bigger defects, we get a higher proportion of dysfunction both in the left and right ventricle. What I would say is that registry analysis tends to underreport dysfunction, just because of the way that we've asked centers to submit data to the registry, which allows for variation between centers in the technique that they might use or the criteria they might use to classify dysfunction. And I think when you look at single center cohorts, we actually see that the rates of dysfunction are even higher than these. So our current thinking about the hemodynamic transition in CDH, which is represented in this figure, is that really this is a disrupted and delayed transition that is that the delay in the disruption is because of the fetal abnormalities in both the respiratory and the cardiovascular system, and specifically from a hemodynamic point of view, that those abnormalities of pulmonary vasculature and potentially also hypoplasia of the ventricle in the fetal state that predispose to early left ventricular dysfunction and pulmonary venous hypertension, which, as I've shown you, can be very severe and is not uncommon, but actually improves quite quickly. And typically we see within the first 72 hours that even severe CDH, severe LV dysfunction can improve. But from that point onwards, we often see ongoing pulmonary arterial hypertension and ongoing right ventricular dysfunction. And with this sort of construct or concept in mind, it can help us to think about when might be the right time to actually operate on these patients. The other thing that we need to think about is what is the effect of the operation itself on cardiac function? And we've got limited data on that, but I'll show you a couple of studies. The first was one that we conducted at Children's Hospital in Melbourne with my friend Florian Monkemeier. Florian's now a cardiologist in Great Ormond Street. Some of you may know him. And what we were interested in at that point in time was right ventricular function, and we were using tissue Doppler imaging to assess that. So the technique is represented in the images on the left-hand side. Basically, we put the tissue Doppler sample gate in position A there in the basal region of the right ventricular free wall. And if you're not used to seeing tissue Doppler waveforms, it generates the waveform that's in the box on the lower left-hand side, where you get two systolic velocities and isovolumic velocity at the beginning of systole, and then a more prolonged S prime or systolic velocity. And measurement of that can give you an assessment of systolic function. And then in diastole, you get this early E prime wave and a later A prime wave. And we know from previous studies that there's right ventricular diastolic dysfunction that is demonstrated as a reduction in that early E prime wave. But what we did in this particular series was looked at that right ventricular dysfunction, that RVE prime wave, over the first days of life in the first week. And what you see is that in two different groups here, a group of milder CDH, who we determined based on a duration of respiratory support less than 21 days, the RV function is better to begin with, and then seems to improve over the first week of life. These are probably the patients that had that mild or moderate pulmonary hypertension that continued to improve over the first 72 hours. But in those patients who had more severe group, who had longer ventilation, they started with a lower RVE prime, so impaired diastolic function. It slightly improved by day 3-4, but then deteriorated again. So this is the group that probably has that ongoing precapillary pulmonary hypertension, ongoing exposure of the right ventricle to high preload. Now, if you look at the panel on the right-hand side, you see the same patients in the pre-op status and then post-op. And again, in that severe group, which is the lighter gray dotted line, what you see is that their function was slightly better than it had been in the first day of life pre-op. That indicates that we waited until their function had improved a little bit. And then post-op, there's a deterioration in function that appeared to happen around 72 hours of age and probably is associated with an exacerbation of pulmonary artery pressure after repair. So really what this data is beginning to illustrate is the potential, particularly in the more severe patients who probably had ongoing pulmonary hypertension, for a deterioration in cardiac function in the right ventricle after repair. Perhaps not too surprising. What about the left ventricle? What does it do at the time of repair? Limited data, and this is data from 2 patients from the Japanese study that I mentioned to you before. And what they've done is they've plotted here at the very top the direction of ductal shunting in those bars that I showed you before. And then below that, they've plotted the LV diameter, LV fractional shortening, and also arterial to alveolar oxygen. And what you see is that in the first patient on the left-hand side, the operation on day 2 was associated with an improvement in left ventricular dimensions, and the left ventricular function assessed by fractional shortening didn't really seem to change very much. But contrast that with second patient who was the one who had more severe pulmonary hypertension with initially right to left and then bidirectional shunting and had a later operation. And what you see is they started with slightly lower LV function going into the operation, and then actually it looks like it deteriorates after the operation, despite an increase in left ventricular size. So maybe giving us a signal in this more severe patient of deterioration in left ventricular function after repair. So combining those two studies, which I would absolutely acknowledge are limited data, we're getting this signal in both ventricles, particularly in more severe patients, for the risk of deterioration in cardiac function after repair. So from the point of view of then trying to decide when might be the right time to operate in these patients, given the current knowledge that we have of this hemodynamic transition in CDH, I think there's a strong rationale for saying, if we know that these patients are at risk of early dysfunction, and we also know that in more severe cases, the function may get worse after operation, it makes sense to operate on them when we've optimized their function, so that they're not going into an operation with existing compromise, or with the compromise minimized as much as possible. And it also gives them that room for movement, or that headroom for deterioration after the operation. So in the schematic here, I would argue that the point of repair should be the point when LV function has improved and RV function has optimized. The question is, how do we determine that point in time? And is it going to be the same for every patient? And I think for the second question, we know already it's not, because as I've shown you in the different series from Japan and from Bonn, we know that different patients will behave differently. And that concept is what was really attempted to be encapsulated in this paper led by Jack Wren in Iowa with Patrick, who many of you will know at the same center, along with Matt Harting, who's a CDH surgeon in Texas and who leads the CDH registry. And it was a pleasure to collaborate with them on this paper. And this is a busy slide, but let me talk you through it. The attempt here was to try and identify different phenotypes of cardiac dysfunction in the early transitional period in CDH and relate those to the optimum timing of repair. So panel A in the top left represents a patient who has that, if you remember that slide I showed you with the different 4 hearts, this is the heart on the left-hand side with normal early cardiac function, minimal early right ventricular dysfunction, and whose pulmonary hypertension is PVR driven, so pre-capillary driven, but that starts to improve quite early on and may have a relatively early repair window. The little arrows at the top are a suggestion of when hemodynamic assessment incorporating echocardiography should be performed. If we go to panel B, that's a patient who's got more of a right ventricular dysfunction phenotype with resistance-driven PVR and ongoing pulmonary hypertension, which takes a little bit longer to improve and therefore has a slightly delayed repair window. Panel C, top right, is a more complex situation where we may have early biventricular dysfunction in the left and right ventricle. We see relatively rapid resolution of the LV, which is both a consequence of time, but also treatment. And that potentially opens up a early-ish window for repair. However, if this patient has ongoing precapillary pulmonary hypertension, then they may have worsening right ventricular dysfunction, maybe around day 3, day 4. And actually, in that case, we may have to treat that and delay the repair window until later. And that's what was represented here by this comment, repair window with transition. And then the final panel on the bottom is one that perhaps we don't see as much, but which is theoretically definitely possible, where there's relatively rapid resolution of right ventricular dysfunction, but then perhaps in the presence of a patent ductus, more left to right flow as PVR falls, and a left to right shunt. And if this patient is left too long, then it may be that they may have more of a flow-driven mechanism of pulmonary hypertension and a delayed their operative window may actually have been missed, and it may be more challenging. Now, this paper is described as a narrative review. It's kind of based on experience being related to create these. Let me show you some real life cases that maybe help to illustrate these phenotypes. The first one is a baby you see described here, right-sided CDH, born at 36 weeks gestation, an OELHR of 40%. So that's an assessment of fetal lung volume antenatally that puts them in a moderate group. And you can see at 6 hours of age, the patient's got pretty high oxygen requirement, degree of pre-postductal gap, and moderate mixed acidosis. And on echo, echo, so even just subjectively, what you can see in the apical four-chamber view is that this patient appears to have a dilated right ventricle, and combining the apical view and the short axis view, even without objective quantitative measures, maybe we can discern that there's a degree of dysfunction in that right ventricle. The left ventricular function, just eyeballing it, perhaps doesn't look particularly impaired, but we can see that septal displacement, particularly in systole, which is going to cause secondary impairment of LV function. Patient has a very widely patent ductus that you can see in the far right panel, and bidirectional flow in that. So this patient has more of the right ventricular dysfunction phenotype, and our objective measures of function, including tissue Doppler, reinforce that. In the tissue Doppler waveform here, in this case in the interventricular septum, and in the RV, we saw reduced diastolic velocities, consistent with early diastolic dysfunction. And when we did strain analysis to measure the the longitudinal systolic strain in the right ventricle, that was also significantly reduced. So we've got objective measures here of right ventricular dysfunction. So the phenotype here is of a patient with precapillary pulmonary hypertension, relatively preserved left ventricular dysfunction, and the approach was to try and help the transition here with pulmonary vasodilators, support RV function. And that patient was given nitric oxide, had a good response, oxygen weaned, oxygenation improved, right ventricular function improved, ductal shunt flipped to more of a left to right pattern, and those criteria were able to be objectively used to inform the timing of surgery at that point. So this patient fitted into phenotype 2, where we were predominantly looking at a resistance-driven mechanism of pulmonary hypertension, and we were waiting for the right ventricular function to be optimized for repair. Here's another patient, patient at 2 hours of age, 38 weeks gestation, severe CDH on antenatal parameters, and at this point in time, they've got severe hypoxemia, severe respiratory metabolic acidosis, and hypotension. And their echo looks slightly different. They've got severe biventricular dysfunction, both subjectively and on objective assessment. They've got systemic levels of pulmonary artery pressure with predominantly a right to left shunt in the ductus arteriosus, and that blood coming across the ductus is actually going back around the aortic arch, as you see in the aortic view. So this patient has more of a biventricular dysfunction phenotype, but a dominance of LV dysfunction. And in this setting, we try and optimize the patient pre-op with inotropy. We avoid pulmonary vasodilators in the setting of pulmonary venous hypertension. We actually made this patient an ECMO watcher because we thought they might need ECMO. But with the medical management, their function improved by day 3, and associated with it, their gas exchange, metabolic acidosis, and their heart rate. Interestingly, they still had RV dysfunction and a right to left shunt in the duct at this point. So at this point, their phenotype had flipped. LV function had resolved, but they still had precapillary pulmonary arterial hypertension and RV dysfunction. So we introduced nitric and sildenafil at this point. And by day 5, RV function has improved. The ductal shunt had reversed, and then the duct had closed, and FiO2 had weaned. And we were able to objectively, based both on physiological criteria and echo criteria, discuss with our surgical colleagues and identify that this patient was ready for repair. And she went on to have a large type D defect repaired and did very well. So she fits more into phenotype 3, where we saw that early pattern of LV and RV dysfunction. LV function improved in the first 48 hours, but then we had ongoing RV dysfunction, which we wanted to optimize before a slightly delayed repair window. And bringing together this approach, this is a schematic. I've slightly flipped it from the image in the paper just to get it on this slide, but it highlights the incorporation of perhaps more historical clinical stability indicators and blood gas parameters with a hemodynamic approach incorporating assessment of pulmonary artery pressure and cardiac function, ventricular function, to guide the timing of surgery. And it emphasizes, yes, ideally being able to reach certain levels of normal function and a predominantly left to right shunt, but in the absence of those, the greater importance of just having achieved stability in those factors prior to repair. In terms of objective evidence of that approach, I'm going to show you some data that's very fresh from our centre and unpublished, and has been collected by a number of fantastic colleagues and researchers in our unit, in particular Emma Bowles, and it relates to 43 cases of CDH where we had early cardiac function data in the first 6 hours of life and used that based on strain assessment to characterize their phenotype, normal, RV, LV, or biventricular dysfunction. And perhaps not surprisingly, based on the approach that I've just shown you, what you see objectively in this cohort is that surgical repair was performed earlier in patients with normal and right ventricular dysfunction alone, and was delayed in those patients that had left ventricular or biventricular dysfunction. So this is just data that tends to or supports and reinforces the approach that with Jack and colleagues we described in the earlier paper. Now, in the last couple of minutes, I just want to throw something a little bit disruptive into the mix, which is the thought of, what about repairing these patients early? Is there a rationale for doing that? And some data to support that comes from this study in Japan, where they measured the diastolic wall stress. You can see what that parameter measures. It's the difference between the diameter of the wall of the left ventricle free wall obtained in M mode, and the difference between the systolic and the diastolic thickness over the systolic thickness. And it's reported as a measure of diastolic function. And in this particular cohort, they operated on these patients at a median of 2.8 hours of life. So within the first 24 hours. So this is very early repair. And what they observed was that the diastolic wall stress, as well as the isovolumic relaxation time as a measure of diastolic function, were significantly improved or higher in the patients after repair than before repair. And their conclusion was that by operating on the hernia, removing the herniated contents from the chest, you remove this constricting or compressive mechanical factor that's compressing the left ventricle, and you improve the left ventricular performance, and in particular diastolic performance. And this idea of early surgery has also been introduced by a group from Israel recently, who reported on what they called a maximum lung protection strategy, which incorporated low pressure ventilation, early targeted echo, support the left ventricle, but also early repair in the first 24 hours. And they argued that by doing that, you avoided exposing the patient to higher ventilation pressures in the first 24 hours. So they were thinking of this as a lung protective mechanism. And as you see in their results, they saw an impressive improvement in survival between the two eras. And they moved from an era where mean repair was happening at 3.5 days to happening on the first day. So what's the concept here? And how do we approach this? I think it's actually an interesting question that is unanswered. With immediate repair, for the reasons we discussed, there may be some benefits of minimizing early lung injury and removing the hernia and any effect that might have on the pulmonary circulation and the ventricle. But it means that we're repairing patients who arguably are in the midst of that cardiac dysfunction and pulmonary hypertension, and it doesn't really leave much wiggle room. So potentially they may be more likely to destabilize peri-op. A more precision approach or traditional approach where we delay repair until hemodynamics are optimized arguably means that the patients are more stable peri-op and therefore have more room for deterioration or any wobbles after repair. But does it risk us increasing the risk of early lung injury to these patients and exposing them to ongoing dysfunction due to the herniated abdominal contents? I finally just wanted to mention also about ECMO because it requires some separate consideration. There are many studies that have looked at the timing of repair on ECMO, and they're nicely represented in this figure, comparing early versus late repair on ECMO and repair on ECMO with repair after ECMO. And there are methodological challenges with all of those analyses. ECMO is a different kettle of fish because during ECMO, there are other risks we need to take into account. Specifically abnormalities around, specifically the risks associated with coagulation abnormalities, either prothrombotic or bleeding on ECMO. And if we're going to repair on ECMO, the challenge of postoperative bleeding. And so in some ways, the hemodynamic optimization of a patient for repair is secondary to trying to minimize those risks of repair on ECMO versus exposure to ongoing wider risks of ECMO. And this paper by Dwi Dow kind of just reinforced that actually in the modern era, if you're going to repair a patient who is subjected to ECMO, it's probably better to do it when they're on ECMO than afterwards. And if you're doing it on ECMO, it's better to do it early than late, because that reduces the risk of them being exposed to developing abnormalities of coagulation on a prolonged ECMO run, and hopefully enables them to come off ECMO quicker. However, in our own practice, I think that if you can phenotype a patient, and particularly if you can identify a patient who has severe LV dysfunction as the main mechanism of requiring ECMO, and that's difficult to pick that out in isolation, but if you think that's one of the main reasons why the patient is going on ECMO, then I would argue that given that we know that it improves quite quickly, it may be that those are the patients where we can give them a short run on ECMO, support the LV through its transition, and then wean them off and repair. And this is just one case where we did that. A patient who had severe LV dysfunction, particularly shown in the short axis view on day one, required ECMO for worsening hypotension and hypoxemia, rapid resolution of that LV dysfunction within the first 48 hours on ECMO. They were able to be weaned off quite quickly, with good gas exchange on moderate conventional ventilation, and then repaired. I have to say, this was a few years ago, and in our current management, this patient might not even have made it onto ECMO. Last slide, and I want to just highlight one exceptional group of patients where early repair may be indicated, and that's where you have gastrointestinal compromise. This is a series we reported who are all small defects, so they had a small A defect in the diaphragm. And probably because the defect is small, they had a complication of the herniated bowel or stomach with volvulus or ischemia. And there were a number of clinical signs that suggested that something abnormal was going on early, including bilious aspirates, excessively high lactates, or thrombocytopenia. But one of the unifying findings in these patients was hypotension. We didn't have cardiac function data on these patients, but I think what it highlights is that if you've got a patient who you think is a mild case, but who has disproportionate hemodynamic findings in terms of pulmonary hypertension, hypotension, cardiac dysfunction, consider the possibility that they might have something acutely compromising their bowel. And in that situation, it's an indication for early surgery to explore and manage that. Okay, so I'm sorry I've gone a little bit over time, but my take-home thoughts are that delayed repair strategies have been applied in the modern era, but with limited objective criteria. Our improved understanding of hemodynamics of CDH during the transition, and particularly the role of functional echo, I would argue have allowed us to apply more objective criteria based around pulmonary artery pressure and cardiac function to determining the right time for surgery. There is a recent revisiting by a few centres of an early repair approach, but I think that needs further thought and exploration. There is actually limited evidence for any approach as we stand here today. ECMO is a different situation, and consider those rare situations where you've got disproportionate hemodynamic compromise as an indication for early repair. But I suppose the real take home is that this is multidisciplinary decision making, and it particularly involves really important collaboration between intensive care and surgical teams. Thanks very much.
Thank you, Neil. That was a fantastic talk. I will hand you all over now to our moderators. So we have Dr. Mamoon Montasta, who we all know is the chair of NeoFOCUS here in the UK, and we have Dr. Nim Sabadar from Liverpool, as well, one of the consultant neonatologists there, and Dr. Zoltan Molnar as one of our neonatologists from Oxford. I'm also really happy to say that we've got Rupa Gopal, who's an assistant professor and consultant in neonatal and perinatal medicine from Cardinal Glenn Children's Hospital in St. Louis in the US, joining us today as one of our moderators, who will also be giving us a talk in the next couple of weeks on CDH. And I'm especially thankful for her for making this time and also shipping her son off very early to school to be one of our moderators. And I'll hand over to these four now. I can see we've got some questions in the Q&A already, so I will leave it to our moderators and Neil.
Thanks, Liam. Thank you, Neil, for this phenomenal talk. As always, brilliant talk. You took us through this journey, lovely journey. So I'll just start off with this question until we get more, and I'll hand over to our moderators and panelists. So obviously, the precision in hemodynamics has evolved quite a lot in the last few years. And I wonder, how did that contribute to, because I used to work with you a few years back, and we used to have many babies on ECMO. Did you find any difference in the rate of patients going to ECMO? And how can we promote for this idea of precision in hemodynamics for not only CDH, but any baby with hemodynamic instability?
Yeah, thanks very much, Mahmood. So I think the role of hemodynamic precision and ECMO in CDH is a whole other really interesting area, definitely worthy of another talk on its own, to be honest. And you're absolutely right. In parallel to us applying a more hemodynamic precision-based approach to the timing of surgery, we've also seen how that's impacted on our use of ECMO, but also our requirement for ECMO. And within our own centre, our requirement for ECMO in CDH has absolutely fallen off. And I know that's also been reflected in the practice in a number of other centres. And there have been some really nice publications from other centres around the world, including the Vancouver group, Baltimore group, Pittsburgh group, and others, and the Israeli group whose data I showed you, where they've seen their ECMO rates really fall off in CDH. And there's two aspects to that. One is, I think, that we've been better able to manage these patients, but the other is that with an understanding of their pathophysiology and the fact that they're transitioning, we're probably more comfortable with why these patients are a bit hypoxic or have lower saturations, let's say, and why they're a bit more hypercarbic. It's not a ventilator issue, it's a circulatory issue. And I think that's allowed us just to let these patients transition more rather than rushing to put them on ECMO just to make the numbers look good. And we've gained a bit more confidence in being able to do that. So yeah, I think hemodynamic precision as having different impacts, including on timing of surgery, but also on our ECMO use.
Okay, thanks, Neil.
Hi, Neil. Thanks very much for another wonderful presentation. I'm just going to take a question from one of the attendees, which sort of reflects one of the questions I was going to ask, really, which is, understandably, you focused on the hemodynamic phenotype here. And the question, I think, is asking, what about respiratory support parameters? What about the respiratory phenotype? Do you take that into account? Is there a way marrying up both respiratory and cardiovascular stroke hemodynamic phenotypes?
Great question. And I think looking to the future and the near future, there's a challenge for all of us who are interested in hemodynamics to bring together cardiorespiratory management. I think in neonatology in general, there's the respiratory experts and there's the hemodynamic interested groups. And I think the next transition we've all got to make is to bring those two things together. And I'm sorry, I didn't talk much about ventilation. What I would say is that our understanding of how the hemodynamics are potentially one of the important contributors to impaired gas exchange in these patients. So the fact that reduced pulmonary blood flow, both in the setting of right and left or biventricular dysfunction, is potentially an important contributor, together with pulmonary venous hypertension and secondary pulmonary edema, to both oxygenation and CO2. It's given us the confidence to actually maintain lower ventilation settings in these patients and not have a response of just trying to ventilate them more to try and improve the oxygenation or improve the CO2, but actually say, this is a hemodynamic problem. Let's focus on supporting, an improvement in pulmonary hypertension and cardiac function. And what we've seen is that as we do that, without adjusting the ventilator and with maintaining lung protective low pressure strategies, where the gas exchange improves. And it reinforces for me that it's a hemodynamic, the important hemodynamic contribution to that. So it's not that I'm ignoring ventilation by any means. In actual fact, we're using our hemodynamic understanding to reinforce a message of lung protection and low pressure ventilation. And I actually think that's a big part of why we're seeing lower rates of ECMO and things in these patients. And it's nice to see that come through in other groups as well, like that data from the Israeli group that I mentioned.
I see there are two other questions in the group, but I do see Dr. Sinha's hand raised. Dr. Ajay Sinha, you can unmute yourself.
I
Should we
don't
take the
think
next
they will
question?
have access to the mic group, so maybe they
Gotcha.
can type in the question if that's okay, Dr. Sino.
Well, in that case, we can take the question that's next on our side. Is it standard of practice to sedate and paralyze these patients, and does this affect decision to repair and risk of complications?
Great question. So first of all, sedation, yes. Paralytics, historically, we're a center that have used them almost routinely in CDH patients. That's slightly historic practice, I would say, globally now. And most centers would look to minimize use of paralytics in these patients. But in the most severe patients, I think in terms of stabilization, there's still a role for using muscle relaxation. It's interesting in the groups who advocated very early repair, which I think is something that needs further exploration before we can truly kind of understand what the potential benefits. But one of their arguments is that by repairing early, you minimize exposure to sedation, you minimize exposure, or if any, to muscle relaxants, and therefore that also helps to support endogenous respiratory function in these patients and speed up their post-operative recovery. So I think it's definitely an important consideration, and I think it's interesting how history has a way of repeating itself, and as we start to come back to re-question the role of early repair, this will be a factor in it as well.
That's fantastic. I think piggybacking on that same question, I know that paralytics can cause some fluid overload. So do you see that in practice pre-op with babies having slightly a higher fluid overload before going into repair?
Yeah, that's another great question around, if you delay repair, do you risk exposing these patients to other things that impair their cardiorespiratory status and make repair harder, including specifically fluid retention? And I think you have to very consciously make decisions that are going to mitigate against that. Fluid restriction, for example. We used to see quite high rates of acute kidney injury, and there are a number of series that have reported that in CDH. And that led us to really think about how we minimize AKI. I think that the left ventricular dysfunction, reduced systemic blood flow, is an important potential contributor to AKI. And we therefore thought hard about how we minimize exposure to other nephrotoxic agents, which might compound that risk of AKI in the presence of low systemic blood flow. And with a reduction in AKI rates, we're seeing patients who are less edematous and therefore in better pre-op condition. But it's definitely a consideration. And muscle relaxation, as you say, is part of that as well, Rupa. Definitely interested what others feel about that. I think, and I suppose maybe the bigger message there is that management of CDH, although I've focused on hemodynamic management, it's often about marginal gains, isn't it? We want to optimize the lungs, minimize lung injury. We want to optimize cardiac function and pulmonary hypertension. We want to reduce the risk of AKI and fluid retention. It's no one single thing. It's a combination of things.
Thanks, Neil. I think Zoltan, do you want to come in?
Yeah, thanks very much, Neil. Brilliant talk. One question, more practical, when we are talking about, and it also was highlighted by the Canadian guideline, then kind of one criteria to meet for or to be eligible for surgery is like normal blood pressure. So in your practice, what do you consider normal in terms of support-wise? Because that's always the interesting thing, that, yeah, the baby has normal blood pressure, but on 300 of adrenaline, Mirinon, plus a little bit of vasopressin. So what you consider normal blood pressure support-wise?
Yeah, a great question. So I suppose in terms of our blood pressure targets, we've become more liberal, you know. So my view is you know, if in a term or close to term CDH patient who's transitioning in the first 72 hours of life, we're not looking for a mean blood pressure. I mean, I don't like means anyway. I like to look at the systolic and the diastolic as a measure of cardiac function, and look at the diastolic to think about where our SVR should be targeted. But let's take mean as an overall summary of that. You know, we shouldn't be looking for super normal means, you know, and we should accept, as long as the lactate's good and renal function's good, you know, a mean blood pressure in the mid-30s is fine, you know. So that's been, you know, a process of acceptance of that's led us to that point. And it's interesting, if you look at the work of the team in Utah, Michelle Yang, Brad Yoder, you know, they've done some really nice descriptions of their approach to CDH. And again, it's the same concept. It's allowing these patients to transition, tolerating lower initial saturations, lower initial blood pressure. And that said, almost all of our severe CDH patients need some support for the blood pressure. And typically we'll use a combination of low-dose adrenaline, epinephrine, and hydrocortisone. And we're cautious about introducing vasodilators too early, particularly introducing milrinone too early, because that will just lead to potentially lowering of the blood pressure early on. So yeah, but I don't know if that answers your question, Zoltan.
Yeah, it certainly, obviously, it starts with that what is the normal you are chasing, because that will have a huge impact what the support the baby is on. And in terms of, if you are not, or if the baby needs like end of week 1, like 300 adrenaline, hydrocortisone, does it consider to be too high to think about surgery? Or if you are not really improving, you are approaching day 14, at some point you just need to bite the bullet and do it, or refer for ECMO?
Yeah, great question. And I think the other thing is, and I think it captured a bit in AJ's question as well, which is, how do we reassure our anesthetic colleagues when the patient is sitting there on a little, you know, some adrenaline, some milrinone, some sildenafil,
absolutely.
Yeah. And we get it a lot in these severe ones where the anesthetists will come and look at that and say, can't you get some of this, can't you get the patient better and get some of this stuff off before we operate? And we have to have a conversation. We say, look, this is the patient optimized. If we try and back off, they're going to destabilize. It's better going into the operation with this stuff on, supporting the patient. But, you know, understandably, they need some reassurance from us that this is as optimal as we're going to get the patient. And I understand where they're coming from, but I think when we've known that patient over the preceding however many days it is, and we've seen them optimized on that level of support, it's easier for us to say, no, this patient was a lot sicker before, they're optimized now, that's the support that they need to have got to this point. Now's the time to operate, because they're not going to get any better. They're just going to
there is no definite cutoff. It's more case by case and whether the patient reached the optimum. Okay, thanks very much. Very helpful.
Okay, thank you. There are a couple of questions about prostin, and I know Rupa has an upcoming talk about prostin, but do you want to answer that briefly, Neil?
Yeah, well, I suppose the first thing I'll say is, you know, wait for Rupa. She's going to give you, she's expert on this, and she'll give you a fantastic talk on prostin and CDH. Just to answer the question, yeah, we use prostin in selected cases. Again, this is about hemodynamic precision in choosing the ones to get it. Our criteria are evidence of systemic pulmonary hypertension with a bidirectional or right to left ductal shunt, a closing duct. So if the duct's wide open, we wouldn't use prostin in that setting. We just monitor it, and RV dysfunction or dilatation. And we've got some data from our center that we shared at the GENS meeting a few weeks ago in Belgrade, and that we're just preparing, hopefully, to submit for publication, that just shows that approach. We think it is important, particularly going into the operation, as a means of optimizing RV function. And in the days before that, if there's different LV function, as a way of augmenting systemic blood flow as well. But Rupa, I'm sure, is going to gonna give us her expertise on that in the next talk.
Thanks, Neil. Any other questions that we have missed? Yes, there is a question about preterm infants and CDH, about the right time for repair for those kids.
Yeah, great question. And I think the question was, was there any evidence for that? I mean, I think or any data, as I've kind of shown you, that we in terms of objective data on timing of repair, we've not got a lot. You know, we're basing it on our previous observations and what we think is a physiological approach. So there's not any specific data that I'm aware of on timing of preterms, although that will emerge as we're seeing more preterm CDH in the era of fetal therapy, where one of the associated risks is preterm birth. I suppose that there are clearly, especially in the more preterm patients, the added complications of managing respiratory distress and waiting for optimization of that. We have seen other situations where we've had some complex decision making around timing of repair. We had a patient who had a combination of congenital diaphragmatic hernia and an intracranial AVM, a vein of Galen malformation. And that led to some interesting thoughts about which should you manage first, or either. You know, is the combination itself just too much of a burden? As it happens, that patient had a good outcome. They had an embolization of the arteriovenous malformation first, and then had the CDH repair. But yeah, there'll always be ones who throw up these complex decision making. And the other important group around that, of course, are the group with congenital heart disease and decision making around when is the right time for repair in relation to management of congenital heart lesions.
Thanks, Neil.
And there was,
perhaps
you
sorry.
go. Yeah, just one thing. It also came up in the chat that what's your opinion, Neil, in terms of taking them off nitric before operation, and so that's always an interesting question. We had one case last year when we operated on the unit on nitric because maybe we were just unable to take the baby off of nitric, then no surgery, so we decided in the end to do it on the unit on nitric, and it went well, I have to say.
Yeah. I think what you described is kind of often the reality, isn't it? The patient will tell us if there may be a surgical and anesthetic preference to get the patient to theatre, which is understandable to do the repair there. But if the patient is too unstable, including having an ongoing nitric requirement, then I think it's safer to do the repair in the unit. I know everyone's setups will individually be different, and that's a factor. We wouldn't generally take a patient to theatre on the oscillator. So if they're on the oscillator, that dictates them having it repaired in the unit. So yeah, I think you're absolutely right. There's these very practical considerations that come into play. It's not just about their hemodynamics, but they overlap, don't they? Because sometimes the hemodynamics will dictate the requirements for therapy, and then that has a practical implication for where you can repair the patient.
Thanks, Neil. Perhaps if I could ask a question. Towards the end of your presentation, you talked about the potential benefits, the hemodynamic benefits of repairing the diaphragm and reducing the hernia. And clearly, if we're aiming for precision-based, individualized care, we need to know in which babies that might be beneficial and in which babies we shouldn't rush to repair. Any ideas about how you identify the babies in whom early repair will be beneficial from a hemodynamic perspective?
Yeah, great question. I'm interested in yourself and everyone else's views on this as well. I suppose the kind of cumulative evidence that we've seen and some of which I shared is that, yes, it's helping us to understand that there are different severity and there's different phenotypes, and to pick out those patients in whom they just don't have a lot of severe pulmonary hypertension or cardiac dysfunction. And arguably those ones might be the first ones that you'd say, well, then early repair is less likely to destabilize them, so why not crack on? But then at the other end of the spectrum, and I think that's why that Japanese data is interesting, where they're saying actually you do the repair and you might actually improve the cardiac function. So as a treatment of the cardiac dysfunction is actually to operate. So I'm not sure that I've got that fully resolved in my own head. I think operating on a patient with significant cardiac dysfunction in and of itself feels like a risky thing to do. But if the effect of the surgery is to actually improve that cardiac function, then I think there's a reasonable rationale in there. But it might be that we end up selecting the very good and the very bad and saying they're the ones that you might feasibly have the best benefit or see the best benefits of early repair. I don't know the answer. I'm not sure. What do you guys think?
I'm not sure I've got an answer for you either, but it seems as if, in very simplistic terms, if we are improving pulmonary hemodynamics by, let's say, unkinking of the pulmonary vasculature in some way, you potentially benefit the RV and the RV afterload. But equally, you might improve LV function with increased pulmonary blood flow and perhaps that diastolic dysfunction. So I can see some logic in that. It's difficult. The difficulty is to try and identify the babies in whom that is likely to make some sort of physiological sense. So I haven't got an answer, but it's an interesting concept, I think. That the repair itself may be beneficial.
I think it's a really interesting question, Neil. But I think the other benefit of hemodynamic assessment is to avoid things that might worsen things, like nitric, for example, and LV dysfunction. So if you do the hemodynamic early on and the baby is not responding to nitric, we know why, and then probably you can discontinue, and hopefully that will help as well, because finding the window is really important, but also choosing the right therapy is really important.
Yeah, and I suppose it's about whether we see the surgery itself as a therapy for the hemodynamics. That's maybe how we've got to reframe it. I don't know. I mean, it's interesting that we're not sure, collectively. Maybe there's an RCT in this. Yeah, I don't know. I mean, RCTs and CDH are hard and they are challenging because it's a rare condition and because of variations in practice. But if there's emerging evidence of potential benefit of early repair, maybe this is a question that lends itself to that.
Great,
I echo everything that you all are saying. And just thinking about early repair, I sometimes feel like babies just give us like a 3-hour window, right? Like 3-hour window of stability. And then it's probably that little piece of that window that we pick up to do the early repair. But that's sometimes successful, sometimes not. And it's just physiology, which is why hemodynamics is so interesting. And yes, inhaled nitric oxide could be used, but there might be babies that love it to start with and then switch their phenotype into an LV phenotype, and that having that assessment is quite helpful.
And I think it's really interesting what you said, Rupa, because just reading all those older papers, where there's a lot of really insightful kind of commentary about what was happening to these patients based on just the physiological monitoring. There's a lot of discussion about the honeymoon. I've never quite understood what the honeymoon was in CDH. Some people have different views about whether it's a pre-op thing, an immediate post-op thing, or whatever it was. But there is this thing, and I think we see it as well, where the patient, from a physiological standpoint, at the end of the bed, the numbers look good for the first short period of time, and then they deteriorate. And I don't think we've truly unpicked what's happening there, whether it's evolving LV dysfunction, worsening respiratory function as a consequence of that. I don't know. I think we're still working on it. But that might then, one way or the other, help us to understand what the role of early surgery is, because I think exactly as you described, people perceive there's this early honeymoon of stability, and maybe that is an opportunity for repair before these patients get worse. But I don't think, I personally speak for myself, I don't know what the honeymoon truly means or what's happening during that period yet. I think that's still another area for really interesting observational study in these patients.
Yeah, personally, I've perceived the honeymoon period as the period where the duct is actually doing its job of offloading, and then it becomes a restrictive physiology, and that's where the honeymoon ends. But yeah, it's very interesting, this period of pseudo-normalization, if you will, that's there.
And Neil, just one very last question from me, if you don't mind. So we obviously, to us, it was a little bit new recognition. Last 5-10 years, it's kind of not starting them on nitric oxide if they are the LV dysfunction phenotype. Can you give us a number roughly? So we are expecting to see that like 10%, 20%. So how many patients you had last year where by oxygenation means, so FiO2 60, in the old days, you would have just started them on nitric to try to optimize. So is it like half of the patients, 1 out of 10, just for us to understand?
Yeah, I'll give you a quick and dirty answer because we're looking at our own data at the moment. But basically what we've seen when we've compared two eras, so we divided management in the past 8-9 years into two eras. And in the more, I thought we would see reduced nitric use in the second era, but actually what we've seen is delayed nitric use. So the time of starting nitric has been delayed, and it's because we're waiting for that LV dysfunction to improve before we start it. Whether in time we'll see reduced nitric use in terms of the number of patients actually receiving it, I don't know. And obviously there's a trial setting up in the US, the NONO trial led by Matt Harting, which is going to look at kind of de-escalation of nitric oxide and CDH. And that's going to be an interesting, really interesting as well. But yeah, we haven't yet seen statistically significant reduction in our absolute proportions of nitric use, but we've definitely seen a shift in terms of when we're using it. We're using it later after the LV's improved. Yeah.
Okay. Yeah. Thanks a lot. And mostly right to left, left to right, interatrial shunting, or more specific markers in the LV?
So what we're seeing, we're using it. Yeah, we've got different parameters, I suppose, that are telling us this patient's got LV dysfunction. You know, objective markers of LV function and left-right shunting at atrial level. So we're not starting nitric at that point. But once the LV improves, if we're still seeing bidirectional shunting in the duct, or predominantly right to left shunting in the duct, right to left shunting atrial level, everything suggesting more of a pre-capillary phenotype, then we're giving a trial of nitric oxide. And interestingly, anecdotally, and it's just anecdote, I think we see more responsiveness to nitric oxide when we give it at that point. Yeah.
And until that happens, you just sit on your hands and you don't start nitric, almost irrespective of the FiO2.
If the patient's improving and the pulmonary hypertension improving, then and they're not in a lot of it, and you're absolutely right, if they've not got oxygenation impairment, then in some cases we're just not starting nitric now.
Thanks. Thank you very much. I just quickly highlight that there is a very nice publication by Neil and his colleagues about the future of CDH in the next 20 years, just to answer the question about the antenatal management and use of AI. So please just go and read this lovely paper. And for interest of time, I'll just hand over to Liam.
Thanks very much. Thanks very much, Neil. That was a fantastic talk, and I've learned so much in that talk, in the discussion afterwards as well. So thank you very much for this talk today. I just want to highlight in the next couple of weeks, so Rupert's going to come back to us and talk. I know there's a couple of questions in the Q&A about the specifically use of prostaglandin in CDH, and Rupert's going to come back to us in a couple of weeks to talk about that. So please register for that. The flyer will be coming out for that soon. But otherwise, thank you all for your time this afternoon, and we'll see you in the next couple of weeks at the next NeoFOCUS seminar. Okay, thanks all. Take care.
Thank you for watching. If you enjoyed this, please check out the other webinars on our channel.